muscles of the back, as well as the pectoral region and the mammary gland, right? I assume you guys have prerequisite knowledge of the bones. Confirmed. You now know the bones and the landmarks, right? And you appreciate the fact that if you look at a bone and you see a projection, that means there's something that is attaching there, right? Be it a muscle, be it a ligament, right? So it's a bit easy to start from the front, and from now onwards until you finish the whole body, it's easier for you to consider everything starting from the exterior, that is skin, superficial fascia going inside, right? And if you're looking at the skin, you have to understand what are known as dermatomes. So a dermatome is an area of skin supplied by a particular spinal nerve. Right. For now, for this region, it's not really important, but when you eventually do the arm, the forearm, and the hand, you appreciate what are known as dermatomes. Right. You'll be having a particular spinal nerve supplying the skin region. Right. But for this one, don't worry much on it. So, from the exterior, you expect to see skin, right? And always after skin, you then have superficial fascia. Right? So after superficial fascia, if something is superficial, you expect something to be deep. Right? Just like if you expect something to be anterior, you see posterior. You see something being superior, you expect inferior. Right? So you have superficial fascia, then you have deep fascia. Right? After the deep fascia, you then expect to see muscles. Right? In any region that you get to. Right? Be it the thorax, the abdomen, wherever. And the muscles that you're going to see in the pectoral region, for now we'll say there are 4 muscles. Right? There's going to be a muscle known as the pectoralis major, right? And if you have the major, that means you expect a minor as well, right? Then after the pec minor, you have a muscle known as subclavius. So these muscles, in a way, they are named in relation to their origin and insertion. For example, if you're looking at clavius, that means clavicle, right? Your collarbone. Do you remember it? Then the 4th muscle, maybe that is more important in this region, is the serratus anterior, right? But before we get to these muscles, let's talk about this deep fascia. The deep fascia that you're going to find in the pectoral region is pectoral fascia. Right? So these muscles are in layers. Right? So if you open up a cadaver, expect to see the pec major muscle first. Right? And we're saying that after the deep fascia, that's where you see the muscles and it. So you have the pectoral fascia. Right? And muscles generally they're enclosed within fascial sheath. Right? So if you reflect the pec major, you expect to see the pec minor. Right? And there's another fascia that includes this pec minor together with the subclavius. Right? For now, you can just appreciate the fascia is known as pectoral fascia. Right? Clavi meaning it's coming from the clavicle, right? Pectoral, it's going to the pectoral region. Right? So it's going to include these 2 muscles. It's a bit easy to remember if you consider that the subclavius is attached to the clavicle. So, originally insertion, I don't really think it's important, but I'll just mention it because it helps you derive muscle function. Right? So for most of the muscles in the body, you find that the origin is always okay. So the origin is always fixed at it. So if you have a muscle that is coming from here and inserting here, that means the muscle will pull towards origin. Right? So insertion moves towards origin. So the pec major, there's 2 heads. Okay? We're going to meet muscles with 2 heads, muscles with 3 heads, muscles with 4 heads, and etc. The pec major has a sternal head and a clavicular head. Clavicular head, meaning it comes from the clavicle, right? Then the sternal head comes from the sternum, right? Particularly the upper 6 course of cartilages. Right? Then this muscle, you've done the humerus, right? And you notice how you had a greater tuberosity and a lesser tuberosity. Then between your tuberosities, there was going to be a bicipital groove. That bicipital groove, as it extends downwards, it forms 2 lips. Right? So you're going to have elevations of bone on either side, a lateral lip and a medial lip. So if you're going to have elevations on either side, you expect a median depressed area. That is your bicipital floor. Right? The muscles that inset on those lips are as follows. Or you can remember them saying a lady between 2 majors of it. Someone is breathing or whatever. So the lady is the latissimus dorsi, which we'll mention in a bit. Right? And the 2 majors, the first major that we've already met is our pec major. Right? The pec major will insert onto the lateral lip of the bicipital groove. The other major that you're going to meet is the teres major. Okay. The teres major will then insert onto the other lip. And we'll talk about it when we get to the pec. Right? So this muscle, the pec major, is saying it originates from the clavicle, the sternum, then it inserts into the humerus, particularly on your lateral lip of the bicipital groove. So, using the same concept, insertion moves towards origin. So you'd expect that muscle to, what's this? Attack 1, medial insertion. Then number 3, all the muscles in the front, from the head up until you get to the pelvis, they flex. It only changes when you get to the lower limb, when the flexors are posterior and the extensors are anterior. So the pec major will also flex. Right? These actions are being executed on your shoulder joint. Right? So at the end of the day, when you then talk about the shoulder joint, when you look at the movements, you now be adding these muscles as the muscles that cause movement. Clinicals associated with the pec major. You can have an absent pec major. If you've seen people who have a depressed chest, right? That's known as Poland syndrome. Right? So if you have an absent pectoralis major, that's Poland syndrome. And in Poland syndrome, you can also have absence of the pectoralis minor, which is the muscle that you see beneath the pec major. Right? So if you reflect the pec major, you see the pec minor. It's a minor because it's smaller, right? So this pec minor originates from the 3rd, the 4th, and the 5th ribs, right? And it sets onto your coracoid process. So remember I said, if you look at a bone and you see a process or an elevation or a tubercle or a groove, that means there's something there, right? If it's a tubercle, there's a muscle or a ligament attaching there. If it's a groove, either there's an artery or a nerve. Right? The pec minor, since it's coming from the ribs, the 3rd, the 4th, and the 5th, and it inserts onto the tip of the coracoid process, that is high up, right? Can you palpate it? But that was the question in last year's paramedics exam. What can you palpate on the scapula? What is to palpate? To feel. Something that you can feel by hand. For example, I can feel the clavicle. So there are 4 things that you can feel on the scapula. What are they? Spine. The spine ends as an abdominal process, right? Can you palpate the inferior angle? You can. Can you palpate the upper body? You can't. Right. So you can feel the upper body because there's a muscle there. We'll talk about that. Then you can palpate the coracoid process as well. Those are the 4 things that you can palpate. Right? So the spec minor, it will decrease the shoulder point. Right? Because it's coming from lower down and it inserts onto the coracoid process. So it will decrease the shoulder. Nerve supply for these muscles will be a bit complex for now because you haven't done the brachial exercise. But just appreciate that there are pectoral nerves, a lateral and a medial. If you use the odds, no, it will tell you that the pec major will be supplied by both the medial and the lateral pectoral nerves. Then the pec minor will be supplied by one, but it's supplied by both as well. Then the subclavius muscle, it's named after its insertion. So it does not originate from the clavicle, but it inserts onto the clavicle. So the subclavius originates from the first corsal cartilage, then it inserts onto the undersurface of the clavicle. If you remember the clavicle, you said that its superior surface was smooth, right? Then the inferior surface was rough. Where you expect to see the trapezoid and the conoid tubercle, then you need the subclavius groove for insertion of this muscle, right? And the subclavius muscle, it will depress the clavicle. Well, it's coming from the first corsal cartilage and goes to the clavicle, so it will pull the clavicle down. So far, so good. Beautiful. Then the serratus anterior muscle. Serratus anterior, that means there's a posterior, right? The posterior ones, you talk about them when you do thorax. They are muscles of accessory muscles rather of respiration. But the serratus anterior muscle, it originates from the upper atrium. Right? And if you look at the scapula, I'm sure by now you know this is the median plane, right? But you also expect a median plane commassurate. So the scapula is commassurate. And if you're going to have this as the median plane, right, at the back, then you have the scapula having, I'm bad at drawing, but anyway, glenoid cavity, whatever, then, so, the scapula, alright, not the scapula, the serratus anterior muscle, right, it's originating from the upper atriums. Then it comes to insert onto the medial body of the scapula. So everything that goes to the scapula inserts onto the medial body, except 2 things that actually originate from the scapula. The teres muscles are the only ones that attach onto the lateral body. So all the muscles that you're going to talk about are not end of the bodies in the scapula. They're coming from the medial body. Then of course you have muscle in the supraspinous fossa, infraspinous fossa, and the subscapular fossa, that is ventral. So every other muscle is coming to the medial body, despite the fact that the lateral body is the thickest. You have seen that, right? Yeah, good. So this muscle, it's coming from the front, then it inserts onto the lateral, the medial body, right? From the medial body, it's going to pull this outwards towards its origin, right? So if this is the midline in the back, confirm the muscle is pulling the bone away from the midline. Right? So that's lateral rotation. It's not medial rotation because some people think you're pulling it to the front, then that's medial. No, you're pulling it away from the midline from the back. Right? So that's serratus anterior. This muscle is innervated by a nerve known as the long thoracic nerve. This nerve will become important when I'll come back for a review of the nerves at some point. But this long thoracic nerve, if you injure it, you get something known as a winged scapula. Right? So if you ask someone to press against the wall, their scapula bulges outwards like a bend. Right? That's a winged scapula. It's different from something known as a dropped shoulder or shoulder separation. We'll talk about that with the muscles of the back. Then the subclavius is a bit easy in terms of nerve supply. You have the nerve to the subclavius. So there's a reason why we talk about these muscles first before we talk about the nerves. Because we then do a nerve and you say it's going to supply a particular muscle that you don't know, that becomes a problem, right? Then, but those are the muscles in the front, right? Then there is something that you find in the superficial fascia. What is that? When you're in the pectoral region. Huh? Guess what we find? Everyone is it. Breast? I don't know your breast. What's the anatomic name for that? Mammary glands, right? So you have the mammary glands which are going to be pretty much the same between males and females. That's pre-pubertal females, right? Then after puberty, you then have proliferation of the breast tissue as a result or under the influence of ovarian hormones, right? Which males don't have. So the male one remains a bit tiny. Then if you look at the female breast, it will extend from its base, it will extend from the second to the sixth, right? That is vertically. Then horizontally, it extends from the sternum to mid-axillary line. What's the mid-axillary line? What's the mid-axillary line? Because over the years, I've realized people just say mid-axillary line, they don't know what that is. What's the mid-axillary line? So, your axilla is the armpit, right? Then it's the region that you do after these things. And if you look at the pec major, at some point it folds on itself to form an anterior axillary fold. Then when we then look at the muscle of the back, the teres major and the latissimus dorsi. Notice these three muscles are the lead between the majors that are going to the bicipital groove and that leaves under it. So these three muscles, they do almost the same thing, except the function of extension and flexion. The pec major is the one that is in the front, so it flexes. Latissimus dorsi and teres major behind the back, so they will extend, but they will still do medial rotation and adduction. Right? So the latissimus dorsi and the teres major, they sort of like fold on themselves as well to form a posterior axillary fold. So you'd find that when you look at the boundaries of the axilla, there's an apex, a medial, a lateral, a roof, right? But the floor is imaginary. So the distance between the anterior axillary fold and the posterior axillary fold, that's the floor, which is imaginary. And midway between those two folds, you expect the mid-axillary line. So it's a reference point. You have a mid-clavicular line, mid-axillary line, then you have the mid-incisal plane, right? So those are reference points. And coming back to the breast, what's more important to understand is the lymphatic drainage. You know what lymph is, right? Excess tissue flow. So the lymphatic drainage is very important to understand because if you look at maybe nowadays, there's a high prevalence of breast cancer, right? Which can also occur in males. So the breast is divided into 4 quadrants. Right? So you have an upper lateral, upper medial, lower medial, lower lateral. Right? So these quadrants, they are drained by different lymph nodes. So when you eventually do your axilla, you look at there are about 4 groups of lymph nodes in the axilla. You have an anterior group, which obviously focuses on the anterior body wall. That anterior axillary group it's found on the undersurface of this pec major. So they are also known as pectoral nodes. Then you have a posterior group that is on the back, right? That will be found associated with the subscapularis muscle. So they'll be known as subscapular nodes. Right? Then you have a lateral group which now drains this upper limb. Right? So this pectoral region, we learn it with the upper limb because it contains muscles that move the upper limb. Right? Though anatomically it's part of the thorax. Right? So having a quadrant like this, right? This being lateral, this being medial. The lateral quadrants, or the upper lateral quadrant, that's where you have 60% of the breast carcinomas occurring. Right? That is the breast cancer. And this lateral quadrant is drained by the anterior axillary nodes. It's something to do. If it happens, you can say thank you, Jesus. Because if the cancerous cells are going to be in the medial group, these medial quadrants, they're drained by the internal thoracic nodes, which are in the thorax. And it's a bit hard to remove those ones. Right? So these ones, the anterior axillary nodes can be removed. You have what is known as mastectomy. Right? Mastectomy is so anything that ends with an omi, you are removing. Right? So in mastectomy, you are removing the breast. And you can have a simple mastectomy whereby you just remove the breast tissue and the lymphatic vessels, right? Or you can have something known as a radical mastectomy. So for a radical mastectomy, you are removing everything. You remove the breast, you remove the pec major, the pec minor, you remove the serratus, you remove the lymph nodes, almost everything. The only thing that you don't remove are nerves. Because if you remove the nerves, you basically won't have this, the upper limb. Because those nerves, they need to go to the upper limb, right? So you preserve the nerves, you preserve the blood vessels. Right? Then this breast, it's mainly superficial, and you'd expect a tail that extends into the deep fascia of the axilla. Right? What's the name of the tail? But that's not what I wanted. But anyways, the axillary tail will extend into the deep fascia. And behind or posterior to this axillary tail, you expect a retromammary space. Retro means, yeah. If you're doing a study which is retrospective, what kind of a study is it? It's you're looking back. So so normally the breast consists of 15 to 20 lobes, right? With each lobe opening at the summit of the nipple separately. Right? So each lobe will have a duct which dilates before it opens. And any dilatation in anatomy, we refer to it as an ampulla. Right? You will meet a lot of ampullas. So you have an ampulla which then opens separately at the summit of the nipple. And each lobe is separated from the subsequent one by fibrous tissue, which forms the suspensory ligament of the breast. Right? And normally, you can slide the breast. Right? That is the skin of the breast. You can normally slide it, right? But within that fibrous septa that is separating your 15 to 20 lobes, each lobe being separated from the next, from the next, from the next. If you have development of, let's say, an abscess, right, secondary to acute inflammation, you're going to find that you're going to have further scarring of that tissue, right? And that suspensory ligament, which was normally supporting the lobes, is then going to pull the skin inward. Right? So you're then going to see a breast that is depressed inward. Right? very particular point. Or you can talk about the nipple. It can be retracted, right? So normally people won't notice that until there comes the time when you want to breastfeed. Then you can't see the nipple. Anyways, then if you look at human beings, right? Human being, our development, I'm sure you guys do general embryology, right? So if you look at the development of a human being, the embryonic development, you find that we go through successive developmental stages of all the animals that we came from. So we are scientists, yes, and we believe in God, but when we are learning, we learn what is there. So evolution. So ontogeny, which basically refers to the developmental stages in a living organism. It recapitulates, or it sort of like depicts phylogeny. Phylogeny being the developmental stages. From you saying you started off as a bacteria, then a fish that can breathe, use whatever, then the fish that can live on the land, then whatever, until you get to the baboon and the human being. So you find that the development of a human being will resemble all those. Just like how you're going to find mapharyngeal hugs, those are unique to fish. But you find them in humans, they will form the head and neck. So for the breast, if you look at cattle, confirm they have a lot of nipples, right? So that is also possible in human beings. So you can get supernumerary nipples, and they will occur on a milk ridge. Right? So normally, only one is supposed to persist, and the others are inhibited. Right? So if those persist, you then get supernumerary nipples. There'll be a line all the way down. Right? Then you can get something known as witch's milk. So when I believe in clinical things, not because you guys are learning to apply these things. You can get witch's milk. A baby is born and they have milk coming out of their breast. What do you think would have happened? So these things are practical, right? So anterior placenta, you all know about the placenta, right? At some point you did biology. And it's normally going to transmit things from the mother to the baby. So imagine, I have a mother who is having those ovarian hormones in preparation for lactating, that is breastfeeding. Then those hormones, they pass to the baby. Right? They're going to cause proliferation of the breast tissue, right? And the baby will be injecting milk because there's the hormone. So it's called witch's milk because in Africa, we then say manaka roiko. Right? Very few people believe in science in Africa. Right? So that's basically the pectoral region in a nutshell. Right? Questions on that before we look at the muscle of the back and the shoulder. What time? I need to be party by 9, but let's look at the muscle of the back. So I'll try to give you the muscles in a way that you remember. So if you look at the back generally, there are two muscles that are superficial. Right? When you eventually go to the dissection movement, flip those can happen. The first muscle that you see, that is triangular, that's the trapezius. The trapezius is a linear origin from a line that comes from somewhere here, going all the way down. So all you need to know is what you find in that line. That's the origin of the trapezius. So it comes from the external occipital protuberance, ligamentum, C7, T1 to T12. So basically, so these things are wait. So these things are basically vertebra. You know vertebra, right? Yes. And vertebra have a spinous process, right? And the first spinous process that you can feel at the end of birthday, that's C7. You cannot feel C6 up to C1 because they are covered by a ligament. It is the ligamentum. Okay. So you cannot say the trapezius originates from the spinous process of C1 to C6 because they are covered. Right. So it originates from that ligament, then C7 to T12. The thoracic vertebra are 12 in number. What? You said it's from C. Cervical. So vertebra are named according to the region. Cervical, thoracic, then in the abdominal region, say lumbar. Then in the pelvic region, sacral, then you have the coccyx, more like the terminal. Then the insertion of the trapezius is the origin of the deltoid. So now you don't need to do cream. So the trapezius inserts into the spine of the scapula, the acromion process as well. But that's for the mid to end, the lower fibers. The upper fibers will insert into the clavicle. So spine of the scapula, the acromion process, then clavicle, right? That's the origin. Spine of the scapula, acromion process, clavicle. Where does the deltoid insert? You say it is bones. There's a deltoid tuberosity, right? Which, if you trace posterior going inferior, you see a radial groove, right? So that's that. Then this trapezius muscle, of all the muscles that you're going to do in the upper limb, is the only muscle which will not be innervated. To innervate is to give nerve supply. It will not only be innervated by the brachial plexus. The brachial plexus will innervate all the other muscles of the upper limb except this muscle. Right? This muscle will be innervated by one of the cranial nerves behind the head and neck. That is your accessory nerve. If you look at your textbook, cranial nerve 11, XI, and Roman numerals. Then this trapezius muscle, injury to the trapezius muscle. Remember, it's coming from the occipital bone, the spinous process of the vertebrae, then it's inserting lower down. So it